Welcome to Studious. Today, we are diving deep into one of the most high-yield topics in all of pulmonology, asthma. This is not just a surface-level overview. This is a complete clinical blueprint structured around the NAEPP guidelines and the landmark 2020 GINA update, designed to take you from zero to mastery. Whether you're a medical student preparing for exams, a junior doctor on the wards, or a clinician who wants to sharpen your diagnostic and management skills, this video is built for you. We are going to cover the disease from its very roots, starting with the pathophysiology happening inside the bronchioles, all the way to how you classify severity, how you choose the right drugs, and how you monitor patients over time. This is a structured, stepwise protocol. Follow every slide carefully, and by the end, you will have a complete mental model of asthma that you can apply clinically on day one. Let's get into it.
To truly understand asthma, you need to understand what is going wrong inside the airway at a structural level. Asthma is defined by a pathological triad, three things happening simultaneously that combine to obstruct airflow. The first is inflammation. The bronchial walls become red, swollen, and inflamed in an episodic pattern. This is the primary target of inhaled corticosteroids. The second component is bronchial hyperresponsiveness, meaning the airways are hypersensitive and will acutely constrict in response to even mild triggers. This is what beta agonists target. The third is reversible obstruction. Air becomes physically trapped behind the narrowed airways, making exhalation particularly difficult. Crucially, however, lung function can return completely to normal between episodes, which is what distinguishes asthma from COPD. These three components, inflammation, hyperresponsiveness, and reversible obstruction, are the pillars your entire management strategy is built around. Remember them always.
Now that we understand the pathology, let's explore the two major etiological pathways that lead to asthma, because knowing which type your patient has shapes both their trigger avoidance and treatment strategy. The first is extrinsic or allergic asthma. This is IgE mediated. The patient typically has a personal or family history of atopy, meaning multiple allergies, eczema, or hay fever. Classic triggers are environmental allergens like pollen, dust mites, pet dander, and floor dust. The prognosis is generally favorable. The second pathway is intrinsic or non-allergic asthma. Here, the mechanism is non-immunological irritation and inflammation. Common triggers include viral respiratory infections, which is the dominant cause in children, and cold air exposure. An important comorbidity here is GERD. Asthmatic patients carry a 3 times higher risk of acid reflux because acid physically irritates the bronchial mucosa. And critically, certain medications trigger intrinsic asthma, particularly beta blockers, which cause bronchoconstriction, and NSAIDs, which elevate leukotriene levels. Also, never underestimate secondhand smoke exposure as a risk factor, especially in pediatric patients.
Let's talk about how the asthmatic patient presents to you. The primary symptom triad you are listening for is a persistent dry cough, shortness of breath, and sudden chest tightness. These symptoms tend to be episodic and often worsen at night or in the early morning, a classic clue. Now, on physical examination, two findings are particularly characteristic. On auscultation, you will hear end expiratory wheezes. This makes complete physiological sense. Because asthma is an obstructive disease, inhalation is relatively preserved, but exhalation is difficult. Bronchoconstriction forces air through narrowed passages during the expiratory phase, generating that hallmark high-pitched wheeze. The second finding is on percussion. Because air becomes physically trapped inside the lung during an exacerbation, chest percussion produces a hyperresonant sound, similar to what you hear when you tap an empty box. These two findings, end expiratory wheeze and hyperresonance, are the clinical signatures of the asthmatic airway in crisis.
Now, how do you confirm the diagnosis? The diagnostic algorithm branches based on whether your patient is currently symptomatic or not.
For patients aged 5 and above who are currently symptomatic, the first test is baseline spirometry. In an asthmatic patient having an exacerbation, you will find a decreased FEV1, that is, the volume exhaled in 1 second, alongside a decreased FEV1 to FVC ratio. This obstructive pattern is your signal to move to the reversibility test, which is what differentiates asthma from COPD. Now, for patients who are currently asymptomatic, and remember, this is common because asthma is reversible and patients can appear completely normal between attacks, you need to provoke the airway. This is done via a bronchial provocation test using methacholine or cold air exercise. A greater than 20% decrease in FEV1 following provocation confirms bronchial hyperresponsiveness and essentially diagnoses asthma. One critical warning: methacholine carries the risk of triggering status asthmaticus, so it is typically reserved for academic settings, while exercise-based challenge tests are considered safer in clinical practice.
Here is a diagnostic dilemma that trips up many students and clinicians. Both asthma and COPD produce the same spirometric picture during an exacerbation, a decreased FEV1 to FVC ratio, indicating airflow obstruction. So how do you tell them apart? The answer lies in the reversibility test. You administer a short-acting bronchodilator, specifically albuterol, at a dose of 200 to 400 micrograms, and then recheck spirometry. In a patient with asthma, the FEV1 will rise by more than 12% post-bronchodilator. This dramatic improvement reflects the reversible nature of asthmatic bronchoconstriction. The airway spasm relaxes with beta-agonist stimulation. In COPD, however, the airway obstruction is structural and permanent, caused by emphysema and airway remodeling. COPD patients do not show significant improvement after bronchodilation. Their FEV1 barely changes. So the reversibility test simultaneously rules in asthma and rules out COPD in a single elegant maneuver. This distinction is one of the highest yield concepts in all of pulmonology. Know it cold.
Let's now map out every drug class used in asthma management, because understanding the pharmacology is what allows you to prescribe intelligently. Asthma drugs fall into two fundamental categories. First are relievers, used for acute rescue. The primary reliever is the short-acting beta-agonist, or SABA, with albuterol being the prototype. SABAs produce rapid bronchodilation by stimulating beta-2 receptors, and they work within minutes. They are used on demand. Second are controllers, taken daily for maintenance regardless of symptoms. Inhaled corticosteroids, or ICS, like budesonide and fluticasone, reduce baseline bronchial inflammation and are the cornerstone of persistent asthma therapy. Long-acting beta-agonists, or LABAs, like formoterol, provide sustained bronchodilation. But here is the critical rule. LABAs must never be used as monotherapy. They are always combined with ICS. Long-acting muscarinic antagonists, or LAMAs, like tiotropium, block parasympathetic bronchoconstriction. And finally, leukotriene receptor antagonists, or LTRAs, like montelukast, block the leukotriene pathway, making them particularly useful in aspirin-sensitive and NSAID-triggered asthma.
We now enter the Stepwise management framework, the clinical backbone of how you prescribe for asthma based on disease severity. Step 1 is intermittent asthma, the mildest category. The clinical profile here is symptoms occurring fewer than 2 times per week, nocturnal awakenings no more than twice per month, SABA rescue use at most 2 days per week, and lung function that is at or above 80% of predicted, completely normal. The patient also requires oral corticosteroids for exacerbations less than once a year. For this group, the primary therapy is simple, a SABA rescue inhaler. Albuterol 90 micrograms per puff, 2 to 4 puffs as needed, used only when symptomatic. No daily controller is required by classical NAEPP guidelines. However, the 2020 GINA update made an important recommendation. Even at this step, adding a low-dose inhaled corticosteroid for daily preventive therapy should be considered because even mild asthma carries an underlying inflammatory component that benefits from suppression. This is a nuanced and testable GINA update. Know it.
Step 2 is mild persistent asthma. Here, symptoms have crossed the threshold of occurring more than twice per week, though not yet daily. Nocturnal awakenings occur 3 to 4 times per month. Daily activities are mildly limited, and FEV1 remains at or above 80% of predicted. This step marks a pivotal shift in management. You now introduce a daily controller medication because the persistence of symptoms signals ongoing airway inflammation that requires daily suppression. The preferred daily controller is a low-dose inhaled corticosteroid, budesonide or fluticasone, taken every day, regardless of symptoms. An alternative is a leukotriene receptor antagonist, like montelukast, useful particularly in patients who cannot tolerate inhaled therapy or who have concurrent allergic rhinitis. Alongside the daily controller, you continue the SABA rescue inhaler for acute breakthrough symptoms. The key teaching point here: once you are in persistent territory, a SABA alone is insufficient. The daily ICS is what addresses the root inflammatory cause, while the SABA merely treats the acute symptom.
Step 3 is moderate persistent asthma, a significant escalation in disease severity. The clinical picture here is daily symptoms, every single day, nocturnal awakenings more than once per week, noticeable limitation of daily life activities, an FEV1 that has now dropped to between 60 and 80% of predicted, indicating real, measurable impairment in lung function. Management at this step is more aggressive. The preferred primary combination is a low-dose ICS combined with a long-acting beta agonist, specifically formoterol, in a single combination inhaler. This is an elegant approach because with formoterol, the same inhaler can serve as both the daily maintenance medication and the rescue inhaler, due to formoterol's rapid onset of action, a strategy known as SMART therapy in the GINA framework. Alternative combinations at step 3 include ICS plus LAMA or ICS plus LTRA, but both of these alternatives require a separate SABA inhaler for acute rescue, since neither LAMA nor LTRA provides rapid bronchodilation. Choose your combination based on patient profile and adherence capacity.
Step 4 represents the most severe end of the asthma spectrum, severe persistent asthma. This patient is suffering continuously. Symptoms are present throughout the entire day. Nocturnal awakenings occur every single night without exception. The patient is extremely limited, unable to perform basic exercise or routine daily activities. And FEV1 has dropped below 60% of predicted, indicating severe persistent airflow limitation. Management at this step requires triple therapy: a medium to high-dose inhaled corticosteroid combined with a long-acting beta agonist and a long-acting muscarinic antagonist, ICS plus LABA plus LAMA. This triple combination targets all 3 components of airway obstruction simultaneously: inflammation, hyperresponsiveness, and bronchoconstriction. A SABA is still provided for acute breakthrough rescue. If the patient remains uncontrolled on full triple therapy, the last resort option is adding oral corticosteroids. However, this is reserved as a final option due to the severe systemic side effect profile of oral steroids, including diabetes, osteoporosis, cataracts, and adrenal suppression.
Understanding the drugs is only half the battle. How those drugs are delivered matters enormously. Inhaler technique is one of the most commonly overlooked causes of treatment failure in asthma. The correct technique requires the patient to fully exhale first, fire the inhaler while simultaneously inhaling slowly and deeply, then hold the breath for a full 10 seconds. In practice, most patients do this incorrectly. They fire too early, inhale too fast, or don't hold long enough, and the medication deposits in the mouth and throat rather than reaching the bronchioles. The solution is a spacer device. A spacer traps the aerosolized drug in a chamber, allowing the patient to inhale it over multiple normal breaths at their own pace, eliminating the coordination problem entirely. Now, 3 critical drug side effects to know. Inhaled corticosteroids cause oral candidiasis, thrush, and patients must be instructed to rinse their mouth with water after every single use. SABAs frequently cause slight tremors due to beta-2 stimulation in skeletal muscle, and oral corticosteroids carry the most serious profile, including diabetes mellitus, cataracts, osteoporosis, and adrenal suppression.
There are 3 critical comorbidities and contraindications that every clinician managing an asthma patient must have memorized, because getting these wrong can be dangerous. Number 1, beta blockers are strictly contraindicated in asthma. Because they block beta-2 receptors, they directly induce the bronchoconstriction that your entire treatment plan is trying to prevent. If a patient with asthma also has hypertension or heart disease, you must choose alternative antihypertensive classes, not beta blockers. Number 2, NSAIDs, including common over-the-counter pain medications like ibuprofen and aspirin, can elevate leukotriene levels in the body. Leukotrienes are potent bronchoconstrictors, so NSAID use can directly trigger an asthma exacerbation. Patients should be counseled to use paracetamol instead. Number 3, unmanaged GERD is a clinically significant asthma aggravator. Acid reflux physically irritates the upper bronchial mucosa, triggering reflex bronchoconstriction. In any asthmatic patient with GERD, treat the reflux aggressively with proton pump inhibitors, because uncontrolled acid reflux will make asthma much harder to manage.
Here is a fascinating and humbling piece of medical history that places our modern understanding in context. In the 19th and early 20th centuries, physicians actually prescribed cigarettes to asthma patients, specifically a product called Grimold cigarettes. These contained a mixture of tobacco, cannabis, datura, and atropine. The rationale was not entirely irrational. Atropine is an anticholinergic agent, and anticholinergics do dilate the bronchioles. So there was a kernel of pharmacological logic buried in a deeply destructive delivery method. Today, of course, we understand the full picture. Tobacco smoke is a primary driver of chronic bronchial inflammation and is directly responsible for triggering severe exacerbations. The single highest yield non-pharmacological intervention you can offer any asthmatic patient who smokes is smoking cessation. Above every inhaler, above every controller medication, if the patient smokes, stopping smoking has the greatest individual impact on disease course and exacerbation frequency. This is a critical counseling point that must accompany every asthma management plan.
The final piece of the puzzle is long-term outpatient monitoring, because asthma management is not a one-time prescription, it is an ongoing therapeutic loop. The first element is at-home monitoring. Teach every asthma patient to use a peak flow meter, a simple handheld device that measures exhalation volume. Used daily, it provides an objective, patient-driven self-assessment of airway function. Declining peak flow readings can catch an impending exacerbation days before symptoms become severe, allowing early intervention. The second element is the 2 to 4 week clinical follow-up, where you formally reassess symptom frequency and repeat pulmonary function tests. Based on this follow-up, you make the critical step up or step down decision. If the patient is failing their current regimen, before escalating medications, always first check inhaler technique and medication adherence, because these are the most common reasons for apparent treatment failure. If the patient has been stable for at least 3 months on their current step, consider stepping down therapy to the lowest effective dose to minimize cumulative side effects. This is the treatment loop: monitor, assess, and adjust. Thank you for watching Studious. If this video helped you, please like, comment, share, and subscribe. See you in the next one.